Hi, everybody. Very warm welcome to all of you to this journal club brought to you by the International Academy for Clinical Hematology across the globe and across the hematology field. I'm Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And it is my great pleasure to welcome you all to this journal club. And this is our first journal club after the August summer break. As you know, the journal club has been established more than 3 years ago by the ICH, and it is proving to be extremely popular. The scientific production is quite amazing, and there are a lot of papers we would like to discuss. For this first journal club of the new academic year, the steering committee has chosen this, we feel, very important paper published recently in the Journal of Clinical Oncology, and the title is shown here, HLA Mismatching and Survival in Contemporary Hematopoietic Cell Transplantation for Hematologic Malignancies by Dr. Esteban Arrieta-Bolaños, and actually under the umbrella of the Cellular Therapy and Immunobiology Working Party of the EBMT. And in order to discuss this important paper, we're very honored and fortunate having Dr. Esteban Arrieta-Bolaños, who is the first author, as a guest panelist. He is a scientist researcher at the University Hospital of Essen in Germany. And the other panelists include the co-author, Professor Florent Malard, from the Sorbonne University, and he's the secretary, actually, of the Cellular Therapy and Immunobiology Working Party of the EBMT. And the third panelist is Professor Arnon Nagler, who is my co-chair of the ICH, and of course, a very famous and top expert transplanter who will share his thoughts with us. So this is the abstract of the paper, and to make a long story short, I think the authors should be praised for analyzing more than 17,000 transplant procedures, looking into high resolution HLA typing, and these are mainly leukemias and myeloid neoplasm. And the other important feature that this analysis is a relatively recent one. The cases were transplanted between 2016 and 2020, which I think reflects the current way of doing transplant. And the other important feature, which I think is of crucial importance to all of us in the field, is the inclusion of more than 1,500 cases who received post-cyclophosphamide. As probably know, post-cyclophosphamide actually has made a clear difference in the way we perform a transplant, not only the haploidentical transplant, but also the mismatched transplantation. I will not go yet into the details, but the editors of the JCO summarized it very nicely, highlighting that these results from a large registry-based study continue to confirm, even at the era of post-Cy, the negative impact of HLA mismatching, especially class 1 HLA mismatching when it comes to unrelated donors. And obviously, this is going to raise some important questions, and I believe this will help to modify or at least to refine our algorithm on how to choose the optimal or most appropriate donor. So without any further ado, I would like to welcome Dr. Arrieta-Bolaños, Dr. Malard, and Dr. Nagler. Thank you for joining us, and thank you all the attendees. We're very glad having you with us. So my first question is going to go to Professor Nagler, actually. And Arnon, you've been following the field for more than 40 years. So before digging a little bit deeper into these results, I would like to hear from you a sort of a historical perspective on why this issue of HLA mismatching has been always important in the field of transplant.
Thank you, Mohamad. I would like first to congratulate Esteban Bolaños and Professor Malard for this beautiful paper. And I think that this is important paper coming from Europe, as opposed to the previous one that mostly came from the CMMTR to the state. I think that broadening the unrelated pool was always a goal, and the HLA mismatching was a challenge always. This paper is important, first of all, for the calcineurin-based inhibitor, because in transplant we have the GVHD, and the mirror effect is the relapse. So it's important because it shows, because we always quote the Mary Horowitz old paper, that allele mismatch is similar to antigen mismatch, and every mismatch reduce the outcome of transplant by 10%. And this was always antigen is equal to allele. And the other thing is the class 1 mismatches versus class 2 mismatches, that in Japan always, and the Southeast Asia, it always was the important or more significant, the mismatch in class 1, and in the Western it was always class 2. And the other thing is the graft versus leukemia effect. So the role of mismatching of HLA on the chronic GVHD and the relapse, and does the chronic GVHD go together with relapse? So this is one aspect. The other very interesting aspect is the PGCY, as you alluded, because there were some controversies, and we heard some titles that with the era of PGCY, HLA is not important, and this paper proved that it's still important in the area of PTCY. The other two issues of the permissing versus non-permissing DP and the B1 leader are new and were not reported in such a big study before. Thank you.
Thank you very much, Arnon, for really giving the context. So now, Esteban, my question to you is, can you explain to our audience, and by the way, guys, you can, of course, jump in and post your questions or comments, and I'll do my best to share them with the panelists. So can you summarize to our audience why you performed this work, and what are the key findings and your own conclusions? And then I'll ask Florent about the clinical implications for the practice of transplant these days.
Absolutely. First of all, I want to thank you, Professor Mohty, and the organizers for the invitation. I think it's a great stage for discussing this kind of findings. So I'm really happy to be here. The question is why we decided to carry out this study. Well, if you already knew that HLA was important, then why do it again? There are several reasons for that. The first one is that the seminal papers that demonstrated that this level of resolution of HLA matching was important in allogeneic transplantation are approaching 20 years in age now. So you can start calling them a little bit old in that sense, right? And it might be that the findings hold, but it might be that the findings are different because transplantation, as you know very well, has changed dramatically in the last 2 decades in many aspects, right? Only in the last decade, we've seen the eruption of PTSI and other strategies to control GVHD. But before that, we had improvements also in the control of infection, the selection of donors, etc. So this has been really an exponential era for transplantation. So that also asks or begs the question, is HLA still important, and are the findings the same? So that's one aspect. We also wanted, as Professor Nagler already hinted to, we wanted to have an analysis that was more focused on European practice, because we know from other types of studies, also in the medical fields and also in transplantation, that sometimes the findings that are produced across the Atlantic are not exactly one-to-one translatable to what happens in Europe or in other parts of the world, because of differences in practice, in the populations that we serve, etc. So that's another aspect. A third, more organizational aspect, is that the EBMT has invested a lot of resources and a lot of effort in strengthening and expanding the EBMT registry, and also guaranteeing high quality HLA data for the transplants that are recorded there. And that is for us really an invaluable resource to do immunogenetic and immunobiologic research related to transplantation. So we wanted to make use of that also. I can also speak regarding the more immunobiological aspects. So in the last 5 to 10 years, we have seen many different models come up as to how to analyze HLA mismatches in transplantation, and we know a little bit better about the biology behind alloreactivity. We have come to understand the importance of the peptides being presented by the HLA molecules, and that has resulted in different models for loci like HLA-DP, but also we have been able to translate some of those findings to other HLA loci and demonstrated the clinical impact. And so this didn't exist 20, 15, 10 years ago even, so we wanted to test those models also in a new contemporary cohort. Of course, the elephant in the room is also PTSI, as we mentioned briefly. That's probably the biggest change that we've had in the last few years. And one part of the project was focused on trying to analyze whether what we find in conventional standard prophylaxis can also be applied under PTSI.
Okay, so we'll talk about PTSI, and we already have some questions about this. So Florent, you contributed to this work, and I think this was a very fruitful and productive collaboration among the members of the Cellular Therapy and Immunobiology Working Party under the leadership of Dr. Katharina Fleischhauer, to whom I say hello, because she has been really contributing seminal findings to our field since many years. So what are the pragmatic, I would say, implications of these findings of this paper, Florent, to the daily routine practice?
So thank you, Mohamad, for inviting me. Thank you also, Esteban, for the nice introduction of the paper and for this very important work. Thank you to you, Esteban, and also, of course, thank you to Katharina Fleischhauer, because it was really a big achievement to perform this very big analysis, and that provides some very important data. First, if we are on the for all patients outside of the PTSI cohort, for all patients, this work highlight that HLA is still very important, and this is highlighted in the paper. We are always speaking that there is a lot of achievement in the field of stem cell transplantation, but what we forgot is that there is a lot of progress regarding the level of HLA typing, and now all over the world we are able to have some high resolution HLA typing for almost all patients. This is very important because this paper confirmed that this is important to have the best match possible. This is always worse when we have an HLA mismatch, but what it says that it is worse to have an HLA mismatch on the class 1, HLA ABC, compared to the mismatch at HLA DRB1 or DQB1. And what is also important, if we focus on the mismatch of the class 1, if you compare some high resolution versus a low resolution mismatch, this is worse to have a low resolution mismatch at the antigen levels. So it's highlighted that this is important to have some very good matching and to have the best matching as possible. It also shows if we have to choose between different kind of mismatch, it's better to have a mismatch on the class 2 compared to the class 1. When we're going to move to the field of the PTSI, people say, yeah, now we are going to use PTSI for haplo, so we can use with 8 or 9 out of 10, it will be the same outcome. Yes, we have a good outcome. Nevertheless, still, the outcome of 8 or 9 out of 10 mismatch will be worse compared to a 10 out of 10 fully matched donor with the use of PTSI. So HLA is still relevant in the era of the PTSI.
Thank you, Florent. So,
yeah,
yes,
just
please.
Esteban, you can correct if I.
No, I think it's precisely that. You know, we wanted to first of all demonstrate once again that HLA is relevant regardless of the platform that you're using for GVHD prophylaxis. And what Florent mentioned about the resolution is also an important finding, because it definitely shows that the you know, having the maximum level of compatibility is something that's desirable in terms of outcome. So definitely very relevant. Yeah.
No, thank you. So my question to you, Arnon, and this is in line with different questions I'm receiving from the audience, is now choosing a donor is not only about HLA, I think. It's also, especially when it comes, for instance, to the haploidentical transplants or the mismatched transplant, there are different parameters. And so where would you position today these findings in the hierarchy of the different findings? And I'm thinking, for instance, about the, DSA, the donor-specific anti-HLA antibodies, but also the other classical parameters like ABO mismatching or CMV seropositivity, gender mismatching, and many more other traditional parameters. What do you think? And then, of course, guys, I will ask the same question.
So traditionally, there were two factors important in transplant. It was the disease status and the HLA matching. I would say that this existed today for me. I think that the other factors, you know, if we talk about haplo, if we go to the Chinese paradigm or to the Baltimore paradigm, are less important besides the donor-specific antibody. The donor-specific antibodies is the most important factor in haploidentical transplant because it's correlates with rejection. And if you have high mean fluorescence above 10,000, you cannot use this donor. So I would say DSA in haplo is the most important one, or because it excludes the donor. But then disease status and HLA. The other factors like ABO mismatch, CMV, gender, it's less important, although the acute leukemia working party, Professor San showed that the three most important factors are the source of graft, bone marrow versus peripheral blood, the age above or below 30, and the female to male mismatch. But I think that still HLA for me is I would say in the haplo third to DSA and the disease status, and in unrelated transplant is second for disease status in the hierarchy.
Thank you. Esteban, any thoughts on this?
Yeah.
No, I would agree with that. I would probably mention the aspect of donor age again, because I think there are really many papers highlighting that in different platforms. I think what we are missing probably is a specific analysis where we are trying to really put those pieces together, because we consistently see that increased donor age in the unrelated setting is detrimental. But how to put that in the context of the HLA mismatch is difficult at the moment. So I think, for example, a study looking at, younger mismatched unrelated donors versus an older matched unrelated donor, that would probably really more conclusively answer the question as to which factor is most important. But I would think donor age is one to keep in mind in the unrelated donor setting.
Okay, thank you very much. So Florent, we have a practical question today, and I think Professor Nagler alluded to, of course, disease status and the importance of disease biology on the final outcome. And so it's not only about the donor or the transplant technique. So today, if we have a very high risk acute myeloid leukemia, and I think this is an important question to all of us in the field. If we have the possibility to proceed to transplant rapidly with an HLA mismatched donor versus waiting a little bit more to refine the choice of the donor. So how would you handle this trade-off between kinetics and how rapidly you can perform the procedure and how quickly you can get the ideal donor? Because of course, if we are able to wait enough, we may end up having the ideal donor.
So this is a very good question, because we are comparing right now, this is a HLA mismatching, and to say that this is worse when we are going to take some HLA mismatch. But of course, we don't have any idea of the kinetic, and if we wait sometimes also to have the better donors on. In fact, if you can wait, this is that we have a low-risk disease or disease that is easy to control. So, of course, probably the outcome of the patient will be better at the end. If you are a very high-risk disease, you have to put into the balance that the risk of relapse, if you're waiting for the best donors available. And you have also to take into account that you're going to give some additional chemotherapy to your patient waiting from the transplant. So you will increase also the risk of morbidity for the patient. So for me, for a patient with a very high-risk disease that is difficult to control, as soon as I achieve the complete response, I will go to the transplant, even with an haplo of a mismatched unrelated donors. But this is not an easy question, but this is what I will do.
Arnon, any thoughts on this?
Yes, I agree with Florent. I will go for sequential protocol and then haploidentical transplant for patients with very high-risk disease, because for the reasons that Florent just discussed.
Thank you. So Esteban, we have, since we're talking about mismatching, and we have a question because people, of course, are very excited about the haplo setting. So within the haplo setting, what is the value of mismatching?
Right. Yeah, that's a great question, because of course you start from a platform where essentially you have mismatches all over, right? So what's better? I think this has been already investigated in a few studies showing that if you look at the quality of the mismatch at specific HLA loci, you can tease out mismatches that are beneficial. For example, I could cite one study from the CIBMTR where they saw that non-permissive mismatches at HLA-DP in this context actually gave better survival in that context, and also DRB1 mismatches. And that the idea is that maybe PTCI is raising the bar of alloreactivity, and you need something that's more immunogenic to be able to favor the GVL responses. Also, we have recently described that for class 1 at least, we can select a specific class of mismatches which are called PBM mismatches in terms of graft versus host or host versus graft directions. And what we are doing now actively is to study that model also in the haploidentical setting. So we don't have the answer yet, but we hope to be able to provide you with one very soon. What we see is that once again, mismatching of certain types can be beneficial in that context, especially if you have a malignant disease that you want to control.
Excellent. Thank you very much. Florent, so and this is very surprising to many colleagues because the common belief was that foci will overcome the negative impact of mismatching. It didn't prove to be the case, at least in this analysis. Probably post-Cy is improving things, but we're not yet bringing the curves at the same level. So, well, first of all, why is this? And second, well, if there is an explanation, I don't know. And second, what are the options in order to further, I would say, get these mismatches closer to the general outcome of the other patient?
So yeah, it's improved things with the PTSI, but still the biology remain important, because what we are doing with the PTSI, that we are going to act on the proliferative T cells at day 3 and day 4 after the transplant, but in fact it remains some T cells, and this is good. Otherwise, we will not have control of the leukemia with the T cells. So, so this is probably why the HLA is still important, is that it remains some T cells and some proliferative T cells, and that the PTSI is not going to kill everything. So I think at the end, it's maybe a good news. How we can improve things, we can see what we can do, because it's to add some more immunosuppressive drugs. I am not sure it will be always the best things to do, because it may increase the risk of infectious complications, maybe also a relapse at the early phase after the transplants. We know that we have some new drugs, we have some abatacept. We don't have some data yet if we combine a PTSI and abatacept, if it improves outcome, but this is one thing we should look at. We can also use PTSI on low dose of ATGs. There are already several reports that show that it seems to be associated with a good outcome. So I think that such analysis will be, that is run in this paper, will be important also to look more closely into the ATG plus PTSI groups in these subgroups. There are some of them in the paper, but we don't look specifically to this group of patients and to see if this is good or not. But we need to have enough patients. And there is also some more innovative strategies. There is also some gut microbiota modulation that is analyzed in some clinical trial that may allow us to improve the outcome of the patient with some new mechanism of action. So maybe it will be also the future to still improve the patient's outcomes.
If I may add to that, I completely agree. And from a donor selection perspective, which is probably something more related to the HLA, I would say that definitely the beauty of PTSI is not only that it improves outcome, it reduces the risk of GVHD significantly, but it also opens the possibility to have many donors for every patient, right? This is especially important for patients from non-European backgrounds. And our colleagues from the NMDP actually show that in their own paper, how so tolerating one mismatch, for example, would increase the available donors to essentially hundreds of donors in many cases. So that's a beautiful scenario where you then can say, okay, how do I select then the best donor for this patient? And in our paper and in our previous publication also, we were able to show that there are subsets of mismatches that are better tolerated. So not all mismatches are created equal, if you want. And so this is going to be, respectively, for mismatch unrelated donor transplantation, really nice, because if we can then validate this and then say, okay, select this or this donor because that's better tolerated, maybe the curves will eventually start going up and approaching the well-matched transplants.
So here, Esteban, speaking about mismatches, we have a question from a colleague asking whether within, for instance, class 1 HLA mismatches, are there any significant differences between A, B, C, or all class 1 are created equal?
No, I think there are differences. If you look at the results in our paper, you can see that HLA-A and HLA-B mismatches are the worst tolerated in general, without looking at the fine script there. HLA-C mismatches tend to be a little bit, so the risk is a little bit lower, but still significantly higher than the matching. So I think there are probably differences across the loci, but most importantly, there are differences in the loci and in class 1 as a whole, because if you consider whether your mismatch is immunogenetically more close to the patient allele or not, you can find mismatches that really do have a different association with outcome. What I'm saying is, again, that the immunopeptidomics that's behind the alloreactivity seems to be playing a role, right? If you have If you then can say, okay, I'm going to select this mismatch because the immunopeptidomics are more similar, you have a difference again between the PBM GVH and the PBM GVH matched. So I think there's potential there for improving selection, and not all mismatches are created equal.
Thank you. Professor Nagler?
Yeah, first I want just to ask two questions. First of all, the cohort of PTCY was much smaller, 1,700. And even in the paper, they discussed that maybe this would not be enough to see, some effects. The other question that it's nice that the paper asks for the clinical impact of PTCY is exactly like the CTN 1703, its improvement on GRFS and the reduction in GVHD. The question that I have is, there is almost no effect or very little effect on chronic GVHD and relapse. So, what is your explanation and take home, to the practice, discussion about this in our clinic? Why it's that? It's a bit surprising, not?
Yes, regarding the first part of the question, we highlighted that the cohort is really big if you look at it in general, but definitely the cohort of PTCY transplants, as you rightly say, is still relatively limited. And I think that's a problem that all of the studies that have tried to analyze this have. We have still low numbers of patients, so we have tried to do the best that we can with the samples that we have, but we have to be careful that, of course, the power is limited still. I hope that in the next 5-10 years, we will have more definite answer, because as we speak, these transplants are accumulating a lot. So that's one word of caution, and that applies to all the studies that have been published so far, I think. The second question, I think the effects from PTCY on the reduction of the risks for acute and chronic GVHD are pretty strong. I think for chronic GVHD, it was probably less strong than we expected, but I think they're still there. The issue with relapse, I think it's really interesting, and we are also puzzled by that, because classically we would have expected GVHD and relapse to go in different directions, right? So if you have more GVHD, then you have less relapse and vice versa. So this is something that we do not observe for class 1 mismatches. We are not exactly sure, but that of course has to do a little bit with the biology of how HLA is expressed, definitely, and how clinical practice is working in terms of controlling the immune response. What we do see, if you look at the general cohort, is once again that if you have HLA-DPB1 mismatches, which is a class 2 locus, as you know, you have reductions of relapse that are statistically significant, and that is quite clear there. So overall, we don't know exactly why in the more recent cohorts, HLA mismatching tends to affect relapse less than what we thought was going to happen. And I think that really warrants some specific research, because relapse, as you know very well, is the worst. So it's the most important cause of death after transplant once they've survived the first months, right? And so there we really need to find if mismatches can still deliver the GVL effect, and which mismatches, because the problem is that they might be blurred by looking at the general picture. So that's something that we need to investigate more.
Thank you very much. One question here, Florent, about the issue, and I guess maybe some colleagues are disappointed with the fact that both sides didn't solve all the problems. The question is about how do you feel about the combination of both Psi and ATG? Because this is now rapidly growing, and many colleagues are adopting the addition of small doses of ATG to post-Psi. Any thoughts on this? And of course, Esteban, you can jump in, and Arnon.
So I think this is a very promising strategy, and as you say, this is rapidly growing. So it shows that people are very interested into this strategy. And it allows us to have a control, because you have the ATG that will induce a T cell depletion of the patient at baseline, but also of the graft when you do it 2 days before and after. So you are already be able to control the T cell proliferations before you add the PTCy. This is also interesting because it decreases the risk of cytokine release syndromes we see after the stem cell transplantation before the transplant cyclophosphamide. So this is very good for the patient already at baseline. And it may also allow us not only to use low dose of ATG, but also to reduce the doses of PTCy. So you will always need to 2 days of PTCy, but maybe instead of using 50 milligrams per meter square per day for 2 days, you can use 40 or 35. You will reduce your dose by 20 to 30%. And we were able to show that we were as effective in the chronic graft-versus-host disease prevention and also acute without increasing the risk of relapse in the patients with this use of lower doses of cyclophosphamide. So I think that in the future, with the combination of small dose of ATG, day -2, on lower doses of PTCy at day +3 and day +4 after transplant.
Thank you, Florent.
Yeah,
Arnon, yes, please,
Sorry, I
Esteban.
wanted just to add one thing. I agree that combination between ATG and PTCy is really attractive. I can tell you that in the cohort that we analyzed, because this is European practice, about 1/4 of the transplants with PTCy had also ATG. So this is something that obviously people are trying actively now empirically, and it would be really interesting in the near future to accumulate more information to see how those transplants do. We couldn't do it because, of course, the numbers are prohibitive at the moment, but that's something that we look forward to.
Thank you for clarifying this. Arnon, we have, yes, please, sorry.
I want to say that you can also look at this on the opposite, like the Chinese are doing. I think they're adding to the ATG protocol PTCy now. So I think that, like Florent say, I think this is something very interesting and maybe very beneficial. Thanks.
So Arnon, I'll stay with you because we have an interesting question from Dr. Kaiser Bashir from MD Anderson, and I say hello to all our friends across the globe, who is asking the question, and you were involved in this, Arnon. There was this paper from the EBMT Acute Leukemia Working Party by Dr. Jaime Sanz, published in Blood very recently, showing that 7 out of 8 versus 8 out of 8 had no impact with post-Cy. Do you see this in contradiction with the current finding from Esteban, or the story is still the same?
It's hard to compare. The cohorts are smaller. It's 7 or 8 out of 8, and here it's a difference of most of the studies from the States, like 1703 or 7 to 8 out of 8. I think that all the field are with still some controversies, you know, I mean, and I think that I would say that HLA matter, and you know, the quote in the JCO paper is bigger, but you know, I don't know how to. Not all the results of all the studies are exactly the same.
But maybe, Arnon, I think one explanation is the Sanz paper was in a very well-defined, well-framed disease setting. And here we have a sort of a bulk, mixed bag of everything. So one is like a sort of a macro view, and the other one is like in a very small microclimate. Maybe post-Cy 7 out of 8, 8 out of 8 is doing well, but on an overall almost public health issue, mismatch. Esteban, do you agree?
Yeah, I definitely agree. I think that is really an interesting paper as well. And I think we have to keep an open mind about the fact that the findings might be slightly different according to the diagnosis, because the biology, again, matters, right? And so what I think, and we want to do now, is to try to see if we can tease out differences between diagnoses. In our cohort, 36% of the transplants were AML patients. And 1/3 was other, the other category, which includes lymphoma and CML and CLL, stuff like that. And then the rest was MDS, MPN, and ALL. So there is, as you say, a mixture. This is like a really an overview of the effects in hematological malignancies. But it might be that we have differences across diagnosis. So we need to study that more, and we are already working towards that.
Yeah.
Okay, thank you very much. In the last couple of minutes, remaining couple of minutes, Arnon, what would you like to see in the future in this field? And the question for you, Florent and Esteban, what are the next steps? So congratulations, great publication. What are the next questions you would like to answer?
So for me, I mean, the most important development in transplant is the PTCY for everybody, and I would like to see more data about HLA, but not HLA importance in the PTCY, but not just HLA, but also the immunobiology, because there are a lot of data about NK cells and T cells and effector cells, and in the first months post-transplant and later on. So we also, there is some, the kinetic is also important, because, for instance, there was some difference in early post-transplant in which class 2 is important, and then it fade in a longer follow-up. And the argue there was about that it affects more the relapse and so on. So we need more studies on PTCY with the immune system, dissecting it longitudinal, what happened to the patient, and also the issue of the age and mismatch. We just published in the TIA paper when we look in the age above and below 35, a mismatch unrelated transplant versus haplo. And, and the results were that we have lower GVHD and lower non-relapse mortality with mismatch unrelated. So, I mean, I think that I would put my money for research in these topics. Thank you.
Okay, Esteban, or Florent, what are next steps? Yes.
Yeah, I completely agree with that. I think we now know PTCY is better in many ways. We just don't know exactly how this works. And once we know how the biology works, we can then try to use it more intelligently. So that's going to be an exciting next decade, I think, for research in that aspect. And apart from the biological aspects, I think that seeing the effect that this is going to have on access to transplantation is something that personally interests me a lot. I hope that this is going to be really something that's going to break the walls for transplantation in many contexts. And then it's up to us to see then how can we further improve the transplant outcome, not just opening the door, but then saying to this person, okay, we're going to give you the best donor that we can, and this is based on this and this criteria. So that's what I would like to see also coming up.
Thank you. Florent?
Yeah, and so I agree with Arnon and Esteban regarding the next step. What is also a very important issue, this is the question of the DSA, because as Esteban said, we need to improve the access to the transplant, but it remains some patient that we can transplant because we have an haplo donor in the family, but we have some DSA with some very high levels, and we know we can't desynthesize them, it fails. And we don't always find some donors into the national registry or at the international level. So it remains an unmet medical need for some patients. And despite the PTCY, despite the haplo, it remains some patient that we can transplant. On one also of the obstacle, this is also the question of the DSA, and we need also to have some more research regarding what we can do to be able to have this patient to transplants.
Well, excellent. Thank you, Esteban. Thank you, Florent. Thank you, Arnon. That was a very nice and beautiful discussion. I'm very grateful. Again, Esteban and colleagues, congratulations for this beautiful work, which was greatly awaited, because as you mentioned, it has been now many years since we had similar analysis, and it was a timely period, I would say, initiative to rejuvenate, I would say, this field. But as we heard from all of you, we still have a lot to do until we can identify the ideal or optimal donor. So this is work in progress, and I think every day there are some great and positive news that are allowing us to improve the way we do transplant. And at the end of the day, it's about improving the outcome of the patient. So thank you all for sharing your knowledge and your opinion. Thanks to our audience. You did great, guys. I do apologize. I wasn't able to take all the questions because it was a very dense debate, but I'm sure you can reach out to the panelists in case there is an urgent question. So thank you all, and wherever you are, please stay safe and keep well, and see you soon at another ICH activity. Take care.
Bye-bye.
Bye, thank you.
Thank you.